With that, I'd like to introduce our keynote, our initial speaker, Dr. David Weber. I've known David for almost 20 years now, and who has built an amazing program at the University of North Carolina. David is certified in internal medicine and infectious diseases, critical care medicine, and preventive medicine. He's been on the faculty at the University of California School of Medicine and a professor of epidemiology in the School of Public Health since 1985. He has authored more than 125 scientific papers in peer-reviewed journals. He's published 4 monographs and more than 100 chapters, editorials, and short papers. I think particularly relevant to what we're asking about now, he serves as the associate editor for infection control at Hospital Epidemiology. His research interests have included the epidemiology of healthcare-associated infections, new and emerging infectious diseases, control of drug-resistant pathogens, immunization practices, particularly of healthcare workers, zoonotic diseases, and epidemiology of tuberculosis. He's a member of the NIH Advisory Committee on Recombinant DNA Research and serves as an ad hoc reviewer for NIH. I can't think of anybody more qualified to lead off this conference on an overview of human infections acquired in healthcare settings. Thank you, David.
Thank you very much. It's a great pleasure to be here. A large topic to cover in the next 30 minutes. And you'll notice that the topic, which I'll take some liberties with, was human infections, not just healthcare associated infections. So, of course, the people at risk in the healthcare facilities include not only the patients for healthcare-associated infections, but also the healthcare workers and the visitors. So I will touch on all 3 of those issues. Let me start off with the major infectious risks for healthcare workers. The major risks are bloodborne pathogens, and those are via the percutaneous or the mucosal exposure. And, of course, the 3 major bloodborne pathogens are hepatitis B, hepatitis C, and HIV. We also have risks for airborne and droplet-transmitted diseases, including varicella, measles, pertussis, meningococcal infection, influenza, and other respiratory infections. And healthcare workers are both at risk for acquiring these diseases, and, of course, when they acquire these diseases, they're at risk for transmitting it to the patients. And then there are the contact-transmitted diseases, either direct or indirect, which healthcare workers are at risk for acquiring potentially, including C. difficile, MRSA, herpes simplex, adenovirus, that is keratoconjunctivitis. And all of these have been described in multiple outbreaks in the literature. We do have to worry about the risk, by the way, of bioterrorist agents. It seems appropriate to mention that here. Person-to-person transmission has been obviously well demonstrated for these diseases: smallpox, pneumonic plague, cutaneous anthrax, and viral hemorrhagic fevers. In fact, the last case of pneumonic plague by airborne transmission I'm aware of in the United States was a nurse who acquired it in 1927 in Los Angeles taking care of an ill patient. We have to worry about potential fomite transmission with some of these agents, including smallpox, anthrax, Q fever, and plague. And, of course, many of the bioterrorist agents are potential laboratory hazards for our laboratory colleagues. Well, what is really the risk and how important is it for healthcare workers? I think that's best exemplified by SARS. As you know, worldwide there are roughly 8,000 cases, roughly 800 deaths, mortality around 10%. But you'll notice that 20% of all the cases of SARS occurred in healthcare workers, and particularly true in Canada, Singapore, and Vietnam, where 40 to 60% of the cases occurred in healthcare workers. Outbreaks in Africa for things like Ebola and Lassa fever frequently involve healthcare workers. And just this week we had an advisory that measles has made it back into the United States. Prominent in that advisory was transmission occurring in emergency departments. This is not surprising because when you're sick, you go to the hospital, particularly in resource-poor countries. They may not have the ability to use proper protective equipment. Even with that, I should say, we have a paper coming out in emerging infectious disease where we took trained healthcare workers, we dotted them with a non-infectious human virus on their PPE. We had them do mock blood pressures on a mannequin and then take off their personal protective equipment. using the CDC protocol. So the CDC protocol was right in front of them, so this was not an issue of training. And 70 to 80% of the time, we could find this non-infectious virus on their skin, hands, and face. So even when PPE is properly used, there may still be risks. Well, in terms of bloodborne pathogens, I've only put up some of them. For those of you interested, can go to this paper. And there are more than 50 agents that have now been described as being transmitted by needle sticks and other bloodborne mechanisms, such as blood transfusion. The big three are clearly hepatitis B, hepatitis C, and HIV. But many, many other agents are listed here, including things such as West Nile and malaria and dengue have been transmitted via needle sticks. So this is a major risk for healthcare workers. The big three, of course, are hepatitis B, hepatitis C, HIV. The risks of transmission are sort of best described by what we call the rule of threes, meaning hepatitis B, if you're susceptible and you get a needle stick with somebody who's infected, it's about 30%, hepatitis C roughly 3%, and HIV about 0.3%. So you can see that hepatitis B is about 100-fold more infectious than HIV. And these are the prevalences in the population. The best data, all this data is from N. Haynes, and this is the best data in the literature. And you can see anywhere from about a quarter of the percent of a population for hepatitis B surface antigen to about 2% for hepatitis C. So these are reasonably frequent diseases. One should also say in terms of overall risks that these viruses are fairly hardy. We know hepatitis B from some excellent work by Marty Favero and others at the CDC remains infectious. So if you take dried blood and put it on a counter, a week later come back and scrape it up as he did and inject it into monkeys, a week later it's still infectious. And we know for hepatitis C that's 1 to 4 days. Fortunately for hepatitis B, we have pre-exposure and post-exposure prophylaxis. And for HIV, well, we have no pre-exposure prophylaxis. We do have antivirals for post-exposure prophylaxis. And as far as I can tell from the CDC website, there's really only been one healthcare worker in the last 5 or 6 years who's developed HIV with our better post-exposure prophylaxis. So the main risk really is hepatitis C, both because it's more prevalent than the other diseases, and we have no pre- or post-exposure prophylaxis to offer our healthcare workers. What are the types of exposures we see? This is some older data at UNC looking at the number of exposure events. This is not the number of people exposed, but the exposure events. Varicella zoster led the list in part because of airborne transmission, although you can see a decrease as we introduced the varicella vaccine at our hospital. Tuberculosis remains a problem, and right now I'm dealing with an exposure due to multi-drug resistant TB. Pertussis, number 4 on our list consistently, and so we're in the process of immunizing all our healthcare workers against pertussis, and then meningococcus, ectoparasites, and miscellaneous other diseases. How many people get exposed to these? This is our data for 2006 and 2007. Again, you can see here that tuberculosis, pertussis, varicella lead the list, zoster because of the airborne or droplet nature. And again, you can see here we had about roughly 80, 90 healthcare workers for TB in those 2 years, with one person developing a tuberculosis latent TB as a result of that exposure. Overall, our rate of healthcare workers developing TB is about 0.4% over the ensuing years. You can see the rest are zeros, and that's because we generally have post-exposure prophylaxis. Hep C is a major concern, as I said. You can see here in just those 2 years we had 50 needle sticks or splashes to mucous membranes with hepatitis C, and we were just fortunate none of our healthcare workers acquired it there. And then, this is why we tell our residents not to run their fingers over strange rashes, because every now and then they turn out to be secondary syphilis. At our hospital, we do protect our healthcare workers. We offer hepatitis B. It's OSHA required to all the people with bloodborne pathogen blood exposures. Influenza is offered, and right now we're at about 80% of our healthcare workers that we immunize. But measles, mumps, rubella, varicella, and more recently pertussis are now required vaccines. We do not recognize religious or personal objections to immunization. For our healthcare workers, we recognize only medical contraindications. And in terms of proof of immunization, they have to bring us written proof. And if it ain't written down, it don't count, and then they'll get immunized again. We've not quite finished all our pertussis immunizations. We've done about 6,000, but we've given our current workers up till June 30th of this year to become immune. And, of course, vaccinia, a number of us have had that vaccine, but we've obviously not introduced that widely at the hospital. So what's happened with this? Well, this is some excellent data showing that back in the mid-'80s, healthcare workers had 3 times the general risk of the population for acquiring hepatitis B. That risk was well related independently to how many years you were in healthcare and how intense your blood exposure was. So a cardiothoracic surgeon had a higher risk than a general physician, who had a higher risk than, say, a respiratory therapist. The OSHA rules came into effect, dramatic uptake of hepatitis B vaccine. You can see the general public went down too, but by the year 1999, healthcare workers had 1/3 the risk of the general public, all due to vaccine uptake. So again, a success story here in preventing hepatitis B. We do offer post-exposure prophylaxis for our workers. We fortunately have post-exposure prophylaxis for many diseases, including hepatitis A and B, and HIV, and influenza A and B, and measles, human bite wounds, which we see occasionally, meningococcal disease, pertussis. Unfortunately, we do have some diseases that we see, mumps, parvovirus B19, and hepatitis C with some frequency, for which we don't have post-exposure prophylaxis. Well, how have we done at UNC hospitals with blood exposures? We've worked hard with the introduction of needleless devices and safety needles and other methods, and we have had some success in reducing our rate of healthcare worker exposures, but the CDC goal for public health for 2010 was 0, and we're clearly not going to meet it. What we've seen is that we are least successful in the operating room, and so with time, the percentage of needle sticks and sharp injuries from the operating room has stayed roughly the same, and therefore occupying a higher percentage of all our needle sticks. And while we've tried to introduce some things such as blunt suture needles, we've had a lot of resistance from the surgeons in using some of these techniques. What about visitors? Well, visitors certainly can acquire communicable disease or serve as a source of infection. Fortunately, this is really an area that's not been well studied. The risk of those visitors giving diseases to our patients and visitors acquiring diseases while in the hospital has not been well studied. There are many cases and descriptions in the literature of influenza, RSV, measles, varicella, pertussis, and SARS being introduced into the hospital by visitors. We certainly had data in the literature of acquisition by visitors of SARS and MRSA. We had one interesting case at our hospital. Clearly was a visitor-related transmission. So we had 2 CF patients. They were on different floors, different wings, different medical teams. One was in isolation, so she never left her room. But because of support groups and other things, the families for the 2 patients were going back and forth between the 2 patients. And the one was on isolation for having B. cepacia and transmitted it to the individual who was not on isolation, we believe via the hands of the families, because there was a molecular match between these strains, and that was the only thing in common between the 2 patients. And I should note that the recent CDC isolation guidelines, which have lots of detailed recommendations about personal protective equipment for healthcare workers and isolation for patients, essentially make no recommendation for screening visitors for infection or requiring the use of personal protective equipment by visitors. So some hospitals are very vigorous and will ask visitors to put on masks and gowns and gloves for patients, say, with MRSA or pertussis. Others will have no guidelines at all, and so you'll see your nurse gowned and gloved and masked, and then, the 6 members of the family, including the aunts who flew in from out of state, sitting in the room without any isolation. And it's really up to the individual institution or the individual locale in the hospital how they manage visitors. So this is really an area that requires further research. With that, let me now turn and talk about healthcare-associated infections. 1.7 million estimated a year. Roughly 99,000 deaths from healthcare-associated infections. Pneumonia and bloodstream infections lead the list at about 30 to 35,000 each. It would rank as the 6th leading cause of death in the United States if we actually ranked it and published it. It would rank after heart disease, cancer, stroke, chronic lower respiratory disease, and accidents. So certainly a major impact, and one of which I'm sure we'll talk more about in the conference. That's generated a lot of public comment and political interest. What are some of the challenges in the prevention and management of healthcare-associated infections? Well, we have changing populations of hospital patients. We have increased severity of illness. We have increased numbers of immunocompromised patients, organ transplant. We now have patients with things like rheumatoid arthritis, ulcerative colitis on immune suppressive drugs, shorter and shorter durations of hospitalization, and obviously to account for these sicker patients, more and larger intensive care units and more step-down units that in many ways are mini ICUs, that is, they take ventilated patients and patients with central lines. So at academic hospitals, at least, a much larger percentage of our patients are critically ill. We have a growing frequency of antimicrobial resistant pathogens and a lack of new antibiotics in the pipeline, particularly for resistant gram-negative organisms, and increasing problems of introduction of multi-drug resistant organisms from the community, such as community-associated MRSA, but also C. difficile with resistance to fluoroquinolones. It's not that we don't know what to do with preventing transmission in the hospitals, that we just can't get people to do it, and the particular problem there is lack of hand hygiene compliance. Some of the future concerns, of course, include issues about prion diseases. In general, when we sterilize or disinfect equipment, it works for every known pathogen. The one exception for that may be prions, and we need to use special reprocessing for prions. Not of a major problem in the U.S. where we're dealing with Jakob-Creutzfeldt disease, but more of a problem in Europe for variant Jakob-Creutzfeldt disease because it's found in lymphoid tissue. Of course, the influenza pandemic, again, we've had multiple pandemics going back. They've now traced multiple pandemics in the 19th and 20th centuries, and so it's really like predicting an earthquake in San Francisco. You know when's coming. You just don't know when, and you don't know how bad, and we're overdue for a pandemic, and you already had a conference on this, but hospitals need to be prepared. Bioterrorist agents, of course, are a concern. And then in terms of new diseases, really new to people, gene therapy potentially, but more importantly, xenotransplantation. So as you know, there's an increasing demand for organs, heart, lungs, livers, and kidneys. We are not keeping up with that with human donations. A number of people are hard at work. The leading animal models, or models for that, will be pigs and baboons. And I would guess in the next 5 to 15 years, we will have the technology either to produce an animal that is stripped of its important immunochemistry antigens or has human antigens on its surface, or improve the immune therapy we can give to people so they don't reject these organs, and we will see transplantation of these organs into people. So we'll now be taking an organ, say, from a pig with all its endogenous retroviruses, other viruses, and putting it into the most possibly immunocompromised person, and we may see introduction of new diseases to humans that way. How about the rates of healthcare-associated infections? Data here from 75, 85, and 2005. The absolute number of healthcare infections in general is going down, but because patients stay shorter periods of time, the rate per 1,000 patient days actually has increased, and much of this is because the patients we deal with are much sicker. Patients, when they do get healthcare-associated infection, stay significantly longer, and this is, in fact, what drives the cost for these patients, particularly true for pneumonia and bloodstream infections, but also true for urinary tract and surgical site infections. In terms of mortality, pneumonia has the highest, somewhere in the 20 to 40% range, bloodstream about 15%, and then lesser infections here, but obviously this is what's driving in part the political interest, not just the cost issues, but the fact that these diseases carry a significant morbidity and mortality for patients. Frequency and cost. There are a couple of nice studies recently in the literature. This is by Dr. Kilgore, and this is percentage of infections and cost by site. They're adjusted to $2,007, and you can see here for all bloods and others, we're talking anywhere from about $4,000 to $25,000 per infection. Another nice study by Dr. Addison, and this was actually picked as the best paper published in infection control, hospital epidemiology each year. Again, tremendous costs associated with ventilator-associated pneumonia and healthcare-associated bloodstream infections. These cost figures were from a meta-analysis in the literature. And again, this is what drives the cost. It's mostly extra hospital days leading to the cost. But healthcare-associated infections, tremendously expensive. This, of course, is our typical ICU patient, flat on their back, lines and tubes, ventilated here, lines and tubes everywhere. Healthcare worker, of course, does have gloves. And of course, this patient is a perfect setup for a healthcare-associated infection. This was a very nice stylized diagram by Bob Weinstein a number of years ago. It makes the point that exogenous flora accounts for probably anywhere from 10 to 40% of infections, and its transmission on the hands of healthcare workers from patient to patient, particularly important for MRSA, VRE, and C. difficile. But the majority of infections are acquired from endogenous flora on the patient's skin or in their body. Surgery leads to wound infections, vascular access devices to bacteremia, being on a ventilator to pneumonia, bladder catheters to urinary tract infections, so you have device-facilitated infections. And then with antibiotic pressures, of course, we get resistant pathogens. This is probably the best, it's about 10 years old, best study in the literature of the prevalence of healthcare-associated infections from Dr. Vincent in Europe. So what they did is a point prevalence study on essentially one day. They looked at 17 countries, 1,500 ICUs, 10,000 patients, and reviewed those charts with the idea of are they infected, and if so, what was the source of their infection. Well, 45% of all the patients in those ICUs in that one day were being treated for an infection. And as you can see, about a third of all the patients had a healthcare-associated infection. 2/3 of those were acquired in the ICU, and 1/3 on the floors. And by far the most important one at that one day was pneumonia. Well, they did look at the risk factors for some of those healthcare infections, and much as Bob Weinstein had already proposed before the study was done, you can see that pulmonary artery catheters and central venous pressure lines, intravenous lines, had a significantly higher odds ratio, about 30% higher risks. Those were leading them short of bloodstream infections. You had urinary catheterization, of course, leading to UTIs, about a 40% in risk, and mechanical ventilation with about a 70% increased risk for pneumonias. More importantly, they showed that it's really not so much if you get a healthcare-associated infection, but when, and the longer you stay in the hospital, the higher the risk. And you'll notice that if you stayed more than 21 days, your risk, and these are not percentages, these are odds ratios, your risk was 75 times higher for acquiring a healthcare-associated infection. So clearly, duration in the hospital was the major risk. The NHSN program, a National Healthcare Society Network, now, and this one report started off with 200 hospitals from 40 states reporting data to the CDC. It replaced the old NIST system. Within the next few years, this number will be into the thousands, both because of a recruitment into the NHSN system, as well as several states are actually requiring all the hospitals to send their data here. It is, of course, the premier surveillance system in the U.S. now for nosocomial infections, defined as an infection not present on admission. The most recent data was from 2006. Now, one does have to realize it does have some drawbacks. First, it's not a randomized selection of U.S. hospitals, and participating hospitals do vary with time. So strictly speaking, it's not a cohort, and strictly speaking, you should not be making year-to-year comparisons. I want to turn just briefly to a couple of the most significant healthcare-associated infections to show you some of the complexities of that. I'll turn first to ventilator-associated pneumonia. So we have inadequate infection control, environmental factors, inadequate staffing. We have contaminated fluids that we would use in the respiratory equipment. It leads to colonization of the upper respiratory tracts and GI tracts in these patients. We all aspirate small amounts from our mouth into our lungs, except patients in the hospital, particularly those on ventilators, aspirate larger amounts of more virulent flora. And then what they end up with is a healthcare-associated pneumonia, and of course they may die from that. What are the numbers here with from the NHSN system? You can see it varies a little bit on the type of ICU. Pediatrics 2.5, the lowest, up to trauma units and burn, the highest at 12. So there's about a fourfold variation in the type of ICU. In terms of the spread, this is the 10th percentile hospital and the 90th percentile hospital reporting data. There's a tremendous spread. So you have here the 10th percentile hospital below presumably 0.1, and the 90th percentile hospital at up around 20, so a 200-fold variation roughly in reporting. And one of the things I've always wondered is, is this all just patient mix? Is it all lack of good surveillance? Is it just randomization, random picking? Or is it something that this hospital's doing right and that hospital's doing wrong. And to my knowledge, the CDC has never really analyzed, 10 to 20 hospitals on this end of the spectrum and 10 to 20 on that end of the spectrum. We might learn a lot about why there's this huge variation in terms of either risk factors or what we can do to prevent it. Let's turn now to bloodstream infections, the next most important infection. Most of the time, those infections are acquired by the bacteria crawling across the skin catheter interface right into the vein, and that's how early on most infections are believed to occur. After that, later on, as this epithelializes, it's the hub where we're entering and giving medications and fluids. That's next most important. Things like hematogenous spread and intrinsic or extrinsic contamination of fluids. There are other issues. We're seeing a number of outbreaks related to compounding in pharmacies for various drugs, and we had an interesting outbreak of Weigellia due to contamination of medications being used to inject for pain relief by the compounding pharmacy. So that's been a problem. And occasionally we still see contaminated fluids, but really mostly either at the hub or the skin interface. Again, let's look at NHSN data. And again, you'll see here, depending upon the ICU, you go from about 1.6 at the lowest ICU up to about 7 in the burn unit, 3 or 4-fold variation or so in rates. But again, when you look at the 10th and 90th percentile hospitals, again, you have like pediatric med-surg, 0 for the 10th percentile hospitals to 10. And again, I think that wide variation remains to be explained. What we're doing, one of the things is the 100,000 Lives campaign from the IHI, and this is probably one of the major interventions in the last few years. Here are the different bundles for bloodstream infections, hand hygiene, barrier protection, that is wide drapes when you put in an IV, chlorhexidine antisepsis, optimal catheter selection, daily review, take the catheter out if you don't need it. Very similar for the ventilator bundle, keep the head of the bed up to prevent aspiration. You do a sedation vacation each day and then assess whether the patient can come off the ventilator, since that's the major risk factor. A couple of other things that really don't have anything to do with ventilators snuck into the bundles, peptic ulcer prophylaxis and DVT prophylaxis. But this has really helped with infections over time. What I did is I took the oldest NIST data, 1992 to 2004, and compared it to the HSN data by ICU here for ventilator-associated pneumonia. And again, strictly speaking, these are different cohorts, but they're large selections of hospitals. And you can see here, we have reduced the rate per 1,000 days of ventilator-associated pneumonia in every type of ICU, with the exception of the burn units. And I did the same thing here with catheter-related bloodstream infections, comparing the NIST data from 92 to 2004 versus the NHSN data. And again, you can see, particularly for things like the surgery ICU, dramatic drops in catheter-related bloodstream infections, again with the exception of every unit except the burn unit. So we clearly are being successful in reducing the risks of healthcare-associated infections. Again, just some comments on the NHSN system. I talked about the variation among the different ICUs and the variation among the different healthcare hospitals reporting. CDC data is often used to evaluate trends, but it doesn't really meet criteria for a cohort. And the data quality is compromised by local sites' ability to apply the CDC definitions, the first issue, and the definitions are somewhat complex. And then there's just inaccuracy of the definitions. Keep in mind, these are surveillance definitions, and so most hospitals are relying on, for instance, an expectorated sputum or suction sputum, infiltrate, fever, white count to define pneumonia. We know using those guidelines, even if you applied those guidelines perfectly, your accuracy in diagnosing healthcare-associated pneumonia is about 50% or less. So there are just problems with surveillance definitions used to measure clinical parameters. Of course, the CDC only focuses on device-associated infections in the ICU. This is only a limited number. We published this data recently in Infection Control Hospital Epidemiology. And even here, we don't have just the numbers from device-related. But you'll see here in the ICU, and all the CDC does is recommend ICU surveillance. If you looked at bloodstream infections in just the medical ICU, catheter-related would be even a smaller number, 78. But out on our step-down unit and our medical ward, we had 180. Similarly, in our surgery ICU, we had 50. and in our surgical wards we had roughly 100. So if you focus just on the type of surveillance recommended by the CDC, as opposed to comprehensive hospital-wide surveillance, which is usually not done, you're actually missing more than 2/3 of all the infections in the hospital. So if we really want to control hospital infections, we may have to go back to more comprehensive surveillance. The goal here, of course, for all our surveillance and our efforts is to understand the chain of infections. You have a reservoir for a bacteria. It has to have a portal of exit from a person, has to survive in the environment. It's got to be a mode of transmission, a portal of entry, an inoculating dose, and a susceptible host. And our goal then is to break this chain of infections. And the most common way we do it is by finding that the patient has a potentially communicable disease and then giving them appropriate isolation. The interventions are surveillance, and that'll be talked about by Dr. Edmond in much more detail. Isolation, contact, droplet, or airborne. Based on the type of transmission we believe that pathogen to have, we use different methods of isolating the patients: gloves and gowns, mask in private room, or an N95 respirator, hand hygiene key, and proper disinfection and sterilization. Of course, drug-resistant bacteria are a continuing problem. This reads here: the next class of drug-resistant bacteria. As humans continue to abuse and overuse antibiotics, the ranks will swell, so go out there and mutate. Remember, that which does not kill us makes us stronger. So the bacteria have about a 2 billion year head start in us eukaryotes, and will win in the end. Problem pathogens in the hospital: MRSA, VRE, multi-drug resistant, extreme drug resistant TB, MDR, Acinetobacter, and Pseudomonas, extended spectrum beta-lactamase producing enterics, and another number of others, particularly Aspergillus, Clostridium difficile, norovirus, which are not really drug resistant, but are major problem pathogens. Factors contributing to the spread in the hospitals include greater severity of illness of hospitalized patients, more severely immunocompromised patients, newer devices and procedures, increasing introduction of resistant organisms from the community, problems with compliance and hand hygiene, increased use of antibiotics. Last time we looked at our ICU, 97% of all our patients in our ICUs were on antibiotics, and that one patient who wasn't in the coronary care unit probably hadn't had his orders taken off. So that's why we generate resistance. I work in a tertiary care hospital. Some of you may work in community hospitals, patients bouncing back and forth. But we're all sending patients to nursing homes where they're not isolated and can transmit MRSA and VRE among each other, and they go home. It's a foreign world we live in, and these resistant bugs make their way around the world. So the new, more resistant strain, invasive strain of C. difficile, started in Canada and made its way to the U.S. MRSA with a dramatic increase, 50 to 70% of Staph aureus in hospitals now methicillin resistant. Here's some data from Cliff McDonald at CDC showing the increase in C. difficile, some of his unpublished data, both as a primary diagnosis, and this has certainly been true at my hospital. This strain, in addition to being hypervirulent due to toxin production, also is quinolone resistant. How do we deal with these drug-resistant pathogens? I'll focus on the hospital. We should give people their recommended vaccines, influenza and pneumococcal. Avoid unnecessary antibiotics, which is easier said than done. Practice appropriate infection control. Avoid prophylactic therapy unless there's scientific evidence for it. And we know, for instance, either intubating a patient or putting a central line, giving them antibiotics doesn't prevent infection. All it does is give you resistant bacteria when you have your infection. Give the drugs at the right dose and time. Use a short course therapy if validated. Practice de-escalation when they have a fever. Start broad, get your cultures, and then narrow down your spectrum. Just mentioned, I'll end up here, and this is the Center for Infectious Diseases. Dr. Hughes, well familiar with that. This is employees must not wash their hands before returning to work because they want to study infectious diseases. Have to always mention, of course, Ignaz Semmelweis, and any discussion about infection control, lived from 1818 to 1865. Had healthcare workers here washing their hands in chlorinated lime, essentially dilute Clorox. He made the seminal observation at the Women's Lying-In Hospital of Vienna. So here's the rate of puerperal sepsis, group A sepsis, in the midwives' clinic, the nurses' clinic. Here's the rate in the physician's clinic. You can see about a threefold difference. When he investigated this, the only difference was that the physicians were doing autopsies and then coming up and taking care of patients. He hypothesized they must be carrying something from the dead patients up to the live patients. Again, this is before germ theory, so we didn't know what they were carrying. But he said that healthcare physicians should begin washing their hands. And you can see as soon as he did that, the rate dropped to similarly between the physicians and the midwives. How well do we do with hand washing? This is in the CDC guideline by Didier Pate and John Boyce. 34 studies, only one study you can see really above 60%. The average of watching personnel was only 40% of the time after a contact with a patient. Healthcare workers perform hand hygiene. Does it work? Many studies in the literature. Here's, again, Didier Pate's study. Using alcohol disinfection as their major way, they increased rates from about 48% only to about 65%, but correspondingly, the rate of MRSA goes down. So, but I can tell you that this is not without problems, as those of you who do, like Mike, infection control, and Keith and others. This is Dr. Semmelweis when he started his hand-washing campaign. That's him 3 years later after they ran him out of the hospital because the physicians did not like washing their hands this way. The rate, by the way, of infections on the physicians' wards went right back up as soon as he left. He eventually died in an insane asylum in Vienna. Hopefully that won't be the fate of the rest of us hospital epidemiologists. Healthcare workers, therefore, at risk for acquisition of infectious diseases, especially by the airborne droplet route, TB, influenza, varicella, measles, and bloodborne. Prevention is appropriate immunization, use of personal protective equipment, and recognition of exposure with the use of post-exposure prophylaxis. Healthcare-associated infections are their major source of morbidity and mortality in the U.S. Prevention is surveillance, prompt recognition of potentially communicable diseases with implementation of isolation, hand hygiene, and proper sterilization and disinfection of equipment. Thank you very much, and I know I had quite a bit to cover. I thank you for your time. Thank you.
Thank you very much, David. That was really a superb talk, and we'll call you back for questions after we have our next speaker. Let's see.